Not surprised. So my name is Dr. Shiri Zaro. I'm an anesthesiologist from the Tel-Aviv Medical Center. I will try to speak slowly as much as I can because I'm a very quick speaker. So today I'm going to talk about, I will do a case presentation, but this one will focus on surgical futility, rehabilitation, and what's in between. So I learned in my life that the most funniest jokes are the true ones. Okay, so we know that we take a frail, comorbid, elderly patient. What is frail? A patient who doesn't have the reserve. And what we do, we take them to huge stress of surgery. And what does the patient do? He fails. Okay? So this patient is a female, 88 years old. She has only hypertension, which is well controlled with medications. She also has a gastric adenocarcinoma, and that's why she's anemic. She had significant weight loss in the last 6 months, and she has progressive functional impairment. If you do the clinical frailty scale, she's moderate frail. Her ASA score is 2, and she's scheduled for an elective laparoscopic distal gastrectomy. Now I ask you, would you operate on her? Do you have any thoughts about it? And is it a dilemma here?
Is it a dilemma? It was a very...
Okay, so what if I tell you that I usually ask the elderly patient, I really like food. So I ask them, what do you eat? And this question raises a lot of issues because most of the patients, when I ask them, they answer surprised their family. And this patient, she says, I eat snacks and I eat sandwiches. And I asked her, why don't you cook? You know how to cook. And she said, I don't have enough strength to stand for 5 minutes, which is about the time to prepare rice. Okay, so her daughter was pretty surprised because this patient can't even stand enough time in order to prepare herself a really simple thing to eat. So this patient, the surgeon saw her as an independent functioning woman. Yes, because she's living alone in home. But surprisingly, she is not. And this is why she's so anemic, so hypoalbuminemic, and she's so frail, maybe. So I asked her, what do you do? Do you go on the farm? How do you get the snacks? And how do you get bread and cheese to get your sandwich? So she says, I asked my granddaughter to do a delivery for me. And I asked her, how do you put the things in the closet? And she said, I wait for my grandchildren to come, and they help me to put it inside the closets. I put only the things that need a refrigerator. So it was very surprising and really sad, and it's really a good way to show you that this dry information says very, very few about our patient. And if we will ask them very, very simple questions, we realize that this patient, which none of the physicians and practitioners that sitting in this room had a dilemma about operating her. Now do you think differently? When I tell you this woman didn't get out of her house in the last 6 months, and she's not able to walk in her house or to stand for more than 5 minutes. So now, is it a dilemma?
No, is it a dilemma? No.
So I want to say, as a geriatrician, that I think that a lot of the things that you mentioned, it's important to understand what are the things here are modifiable, and also what are a factor that are because of her gastric adenocarcinoma, right? Because patients with gastric adenocarcinoma don't eat well, they lose weight, and they become weak. And in that case, when we talk about frailty, it's also important to discuss what are the contributing factors to frailty. And if the cancer is a contributing factor, then we need to have the discussion whether or not treating this cancer by operation with chemotherapy or without, would that help reverse these components of frailty.
Any other comments?
I would say that in her current state, she will not be able to do the ERAS program or any post-habilitation after surgery. So in order to undergo the surgery, whether the distal gastric adenocarcinoma is the cause for her frailty, we must first do a serious rehabilitation program about this patient, because at her current stage, she is not fit for surgery.
Okay, So I'm gonna make a spoiler. Okay, this is not a good case. Okay, we are all. I'm the bad news person. Everyone who knows me knows that. And I'm not afraid to talk about the bad things and about the poor outcomes, okay? Because we all present our good outcomes, and what about the bad ones? We can learn much more from the bad ones than the good ones. So, we don't have a rehabilitation program, so this patient went to surgery. I intentionally didn't include numbers and facts, medical dry facts in my presentation, because I don't want us to focus on that. I want us to focus on other things. So the anesthesia and surgery went uneventful. She was extubated in the OR and she was brought into the PACU. The PACU stay was also uneventful. She was discharged to the surgical ward, and then she had a 53 days admission. Okay, why? Because she had recurrent aspiration and subsequent recurrent pneumonias. She couldn't be enterally fed whatsoever, not per os, not by a nasogastric tube. She had to, we had to make her a PICC line, and she was had a TPN nutrition. She had suffered in these 53 days hospitalization. She suffered severe functional impairment, not surprising for an 88 years old that is hospitalized for such a long time. She lost her autonomy, okay, because we discussed before that this woman, she lived alone in her house, she showered alone, she went to the toilet alone, and now she is ADL, total dependent. So after 53 days, the surgical physician, they understand they don't have anything to offer for her, and she was transferred to the geriatric ward. She spent there 21 days. She had a persistent severe functional impairment. They couldn't improve her whatsoever. She couldn't even eat alone. She had a moderate cognitive impairment, which was new. They did manage to start per os nutrition, but the calorie intake was really, really low. And they recommended her to go to a nursing facility. Unfortunately, the family refused, and she was discharged home accompanied by her family. She arrived 7 days later to the ER by the family due to altered level of consciousness. She was very, very depleted, and she had another 32 days admission. The diagnosis was UTI. It was resolved very quickly and easily with IV antibiotics, but her functional status did not improve as well or at all, and she returned to the PICC line and to the TPN. Her consciousness level didn't improve much during this hospitalization. She was bedridden, she was immobile, and she was cognitive impaired. And finally discharged after 32 days to a nursing facility, and we say complex nursing facility, because she had many stress ulcers, and she had a TPN nutrition, which is really it's complex to treat. So this is really a bad outcome, okay? Because I say, if we always talk about postoperative mortality, okay? We say 30 days mortality, we say 90 days mortality. Okay, these people that die, it's not, I know it's not a positive outcome to die, but I think it's much worse to be hospitalized and to be very functionally impaired and independent, dependent and immobile for such a long time. I think it's much, much worse, and I think we all agree about it. And then I will ask you a few questions. The first question is, was this a futile surgery? Okay, and we need to say that some surgeries are futile, and how do we recognize these patients that are potentially going to have a futile surgery? How do we treat them? How do we what alternatives do we give them? I will ask you, did we have an opportunity to optimize these patients? Could have we done something different? And I also will ask you, is postoperative mortality a good outcome for geriatric patients?
Well, so many good questions, but I think that one of the good questions that you have addressed is the question of futility. I think it's a very, very difficult definition, because how do we define futile surgery? If it was a successful one, then it wasn't futile. So I think the question is, what is your intention? Intention to treat, intention to do palliation, and futility, I don't know. For sure, this patient wasted the prognosis of her disease on being hospitalized and lost everything. Could we know it ahead of time?
Thank you. I think, well, the first thing I want to comment is that I think if she stopped the presentation after describing how surgery went, I think many people in the audience would be very happy because surgery was successful. And the patient didn't even suffer in package, was discharged to the ward. It's a great success. I think many people in the audience would consider that to be a great success. The patient didn't even die. As she said, if the patient died, if surgery was successful and the patient died, that's one thing. But this surgery, many people would mistakenly, I think, consider this case to be a great successful case. And therefore, I think that now that we know the end of the story, that's why I think it's so important to try and talk, discuss, and maybe even define much more complicated outcomes than alive or dead versus or with cancer than without cancer. I think this is a great example of a great surgery with very bad outcomes. We are actually trying now to define what we call surgical futility. I know this raises a lot of questions. It's a very complex and sensitive and a not easy topic to describe, but I'm very, very confident, as Shiri said, that we can no longer define surgical futility in terms of mortality only, because that would be very wrong.
I am more or less an old surgeon. I'm an old surgeon, and in the 80s we published a paper on adenocarcinoma of the stomach in the elderly patients. And the conclusion was no palliative surgery and try to avoid total gastrectomy after 80 years old. That was the main, but it was essentially based on the morbidity, mortality, post-operative morbidity and mortality rates. And it was quite the same as younger patients if we select the patient by operability and resectability with what I just told you. But by the way, it's not completely the way to handle those patients. And this case is clearly demonstration of that. That's the reason why in the department from where I come, and Lisa knows very well, they built algorithms and tables of prediction of death apart the carcinoma. And this is one of the decision making. And when we send the patient to the geriatrician, first of all, because of the frailty, they say if they think that you can do the same treatment as the younger patients, only one option without chemotherapy, without chemotherapy, or the same. But the other question is the expectancy of life and the cause of death and prediction of death apart the cancer. And this is very important because if you have a cause of death within 3 months for other reasons, and they know how to calculate that, there is no reason to operate the patient, and because this patient for sure will not have a very long expectancy of life. And this should be known before making the decision of operating or not. Do you agree, Lisa?
I agree. I think I agree, but I have some issues with that, because I think that in here, if you have looked only on post-operative mortality, she had a good outcome, because her 30 and 90 days mortality, she didn't have mortality. So if I look only at mortality, I would miss this patient and a lot of other patients, which I feel that this is much of a worse outcome. So if I tried to cure the patient, I succeeded, okay. I didn't succeed and the patient died, that's okay too. But if I disabled the patient for such a poor outcome, so this is the place where I feel the worst as a clinician. So yes, I agree that this patient, if she had no life expectancy, we shouldn't have operator. This is another kind of futility. This is futility like we don't operate on metastasis, yes, because there isn't medical. The patient will die from other medical reasons. We shouldn't have operator because it's fatal because she's not potentially be living anyway. But I think this is another kind of futility.
You have another case, right? So
no, I deleted the other case, but I can. We can talk about other case. I can present another one that I saw in the clinic. But I just wanted to make the point that it's important, but it's not the only futility we need to relate. We need to also relate the futility that is not defined as a mortality, and this is very important for me.
I think as a simple person, I try to make the problems and the solutions simple, and I think in the end, after the papers and the tables, I think that the answer is very easy. Did we increase the life quality, or did we increase the livity? And in the end, everything comes to it with regards to the wishes of the patient. If the patient doesn't want to end his life in an institute or in a hospital, or on the other hand, if we sometimes more in emergency general surgery cases, we give the patient several days to say goodbye to the family. I had a case with mesenteric event a month ago. The patient lived a 90 years old man with a list of diseases. We operated. He got extubated, and he had enough time until his children came from that and say goodbye. And in the end, this surgery was not futile. So I think in the end, everything comes to those two questions and the wishes of the patient.
So a few things. Number one, this is a perfect case of a lady that needed prehab, right? I mean, everybody here in the room, I think, understands that she was depressed, she was starved, she was wasted, and it went unrecognized. And there's a very famous, not exactly a rhyme, but a story for Not For a Nail, where you should look it up sometime and see somebody makes a small mistake, you're missing a nail on a horseshoe, and you lose the battle at the end, and then you lose the kingdom. If you ask me, in the words of one of my great teachers, Yonamani, he would have said that there was an underassessment here, and the underassessment was leaving the OR without a feeding tube. So in this case, this patient needed a feeding J tube. A third of people over the age of 80 aspirate as a baseline. Okay, so if you're already going to operate on her in this case, and what I learned in thoracic is how to prevent pulmonary complications. So she should have left the OR with a feeding tube. She should have gone to intermediate care, if not the ICU. That's the second mistake. Not because she needed it, but because she needs the nursing. So one of the things that I've learned coming back to Israel in the last 6 months is that on a ward you have 8-to-1 or 10-to-1 nursing ratios. the trays get put in front of them, the residents get them to eat way before they're ready to eat, and then it's a Greek tragedy that is understood ahead of time, really. So this patient needed a different type of nursing, a different type of physical therapy post-op, a different type of nutritional plan post-op, and in the words of Professor Kashin, who actually put this meeting together, you only get one chance to make a first impression. And so if you blow the chance on an old person, then you have this Greek tragedy. But she didn't have to have this outcome, and coming to the conclusion that she shouldn't have surgery, I think, is a grave mistake. It's just, if she's going to have the surgery, you need to give her the support system that can actually take her through it safely.
Thank you. But I don't think that even with a J-tube after surgery, or I think the outcome would have been the same. It's not about just these details. It's about the concept. It's about the philosophy.
As for futility, the definition for futility in the dictionary is useless or of no value. This is a decision to be made before the operation. It's not based on the result. If the patient died, you can say it was. If it did not die, it was not. To remove what looks like operable gastric cancer is not futile. It's something that the patients need. This tumor, if you live in not very long, the tumor will grow, and we don't have good palliative measures. We can pull out a colostomy, and she will die with big agony, with a huge mass in her upper abdomen that we can do nothing about. So futility, it's not. Here in this case, it's a demonstration that maybe defines this whole day. So what did not happen? She was not prepared for surgery, simple as that. And as we will never think of taking a gastric patient to operation without MDT with the oncologist, like you said, or a gastric or rectal cancer without considering radiotherapy. This patient should not have gone to surgery. Maybe after evaluation, we would consider not to operate, but she was not even evaluated, so we don't know.
But I must disagree about the definition of futility. This was the definition of futility in the Hippocrates time, okay? That medical treatment that doesn't improve the problem that the treatment was given for. This is the old definition for futility. Today we know that there is qualitative futility and there is medical futility. And as we say, even if the problem was solved, but the patient didn't earn from the treatment as a whole, this procedure or treatment was futile. Because if we cure the cancer, but we don't improve the patient, if we have an unbearable quality of life, then it can be considered as futile. And this is very controversial. Yeah, but this is from the literature. It's not. This is the.
I want to say that I think Shiri is doing something very brave. She's sitting in a room full of surgeons and talking about surgical futility. And I know the word futile is very strong and it's very controversial, but the point still remains. It's very obvious that some of our fellow surgeons in the room are trying to find technical solutions to a bigger problem. Yes, it's true, sometimes a better technical solution, like preparation, like multidisciplinary team discussion, like a feeding tube, we can find some solutions for some unwanted outcomes, but the question still remains in the room. Are there times in which surgery is not the right solution, even if the oncology would say that surgery is the right thing? But for the patient, we're talking about patient-centered care now here. Some patients would probably be doing better according to their perspective, not my perspective. I have my own perspective. If I were the patient, I know what I want. But we need to start talking about what patients find as important when they have such a disease. And sometimes the solution is not surgery, even if we, as surgeons, think that the best way to remove this cancer is by surgery. This is just not always the right solution.
Yeah, I agree with that. Yeah.
Just a last comment. I think this is a great opportunity to talk about what we measure. And we're so used to, and if in this room there are people who write papers in surgical, geriatric surgery, I think it's about that. It's about measuring, not mortality and not length of stay. Let's talk about where they go to, what is their disposition, what is their function in 3 months, and talking about their goals of care before and then looking if they achieved their goals after surgery. And I think we need to rethink, and I think that's part of the reason that we kind of felt that this society makes a lot of sense, because we also need to talk about writing the literature different, right? I mean, we're human beings, but we are the people that are going to write this literature.
Okay. So I will just answer that, and I will continue with my presentation very quickly. So we are currently working on a paper that we decided to look at surgical futility and not just as postoperative mortality. We used the patient-centered outcome, daily life and out of hospital, and we measured the daily life out of hospital in the 90 postoperative days. And we decided that futile outcome would be more than 45 days of hospitalization in a 90 days period, which means that the patient was more than 50% of the 90 postoperative days hospitalized in the hospital, not in a care. And you think it's very hard. I'm not saying it's easy. Okay, it's not the subject of the it's really controversial, but. It's very controversial, but I say this is it's one tool of a basket, you know. We just need another tool in our baskets because postoperative mortality is not enough. This is the only thing I'm going to say. And of course it's controversial and debatable. So I just want to take this and say what if, okay? So I took one study of many studies of rehabilitation, and I like this study because they looked about quality of life. And here they took patients and 70 and older going for a colorectal cancer surgery, and they took them into a 3-week rehabilitation program. They looked at postoperative length of stay, the disposition after discharge, 30 days mortality and morbidity, and quality of life assessment. And they had 3 weeks of all nutrition recommended by dietitians, and 3 weeks of physiotherapy, and a geriatric consult and a cardiovascular consult. And they had, it was eventually 58 patients were compared to 23 patients in the era before they started this rehabilitation program. And the baseline characteristic was similar between the groups, except the rehabilitation group had more laparoscopic surgeries. So they, of course, adjusted for that. And we can see that the median time to discharge, the length of stay, was shorter in the rehabilitation group, even after adjusting for the type of surgery and the invasiveness of the surgery. So I also interested in the quality of life of this patient. Of course, here they looked only on the group that had rehabilitation because they had given the questionnaires. But we can see that the patients were more satisfied and had better quality of life after surgery than before, which is very important. So the bottom line of this study was that a standard rehabilitation program can contribute to reduce the duration of hospitalization and improve the quality of life after surgeries. And this is great, but I asked, what about readmission? What about the functional status? As you said, what about disability? What about their cognitive function? And what about the maintenance of autonomy? Can we change that? And my question is, can rehabilitation alter the postoperative trajectory of a patient? Okay, we see a patient, we assume his trajectory. Can we divert this by rehabilitation? Can rehabilitation program potentially aid this futility curve? And can we optimize the patient with high futility potential and decrease the risk for a futile outcome? And again, I say it's the most important thing is to select, to optimize whom can we optimize. Select again if the optimization really went well, and then to see if we can operate this version. this person. And really what I want us to see is that we see an elderly patient. There are some that it's clear they are fit for surgery, some that it's clear they're unfit, but there are some in the middle. And the patients that are in the middle, if they would have rehabilitation, would they be fit for surgery in the end? And if they do, I think it's something it's very, very important to invest in. And it's going to be an absolute win for us, for the patients, and also for the system. So, a lot of things to think about.
כן, את מדברת מהר, זה נכון.